point, you call it as tertiary hyperparathyroidism. So it is not a separate entity as such. Tertiary hyperparathyroidism can be considered as a stage of secondary hyperparathyroidism when the gland starts autonomously secreting the hormone. So that's about the three forms of hyperparathyroidism. Now about disorders related to calcium. So I'll be now telling you about hypocalcemia and hypercalcemia. And before we discuss about disorders related to calcium, we know that there are two forms of calcium that can be estimated. One is total calcium and the other one is ionized calcium. And total calcium normal range is 8.6 to 10.2 milligram per deciliter. And when I started the discussion, I said 50% of total calcium is the ionized form, right? So it has to be half of it. So it is 4.6 to 5.3 milligram per deciliter. And most laboratories estimate calcium as a total calcium. Ionized calcium estimated through ion selective electrodes. So only when you specify that you want ionized calcium, you're going to get a value for ionized calcium. Otherwise, what you get is a total calcium value. So these are the two forms of calcium. Now, because we have two forms of calcium, there is a possibility of pseudo hypocalcemia and pseudo hypercalcemia. So what is one clinical condition that can present a pseudo hypocalcemia? That is hypoalbuminemia. So what happens in hypoalbuminemia? In this condition, for a given total calcium, when there is hypoalbuminemia, the bound fraction decreases. When the bound fraction decreases, you know there is going to be an increase in the ionized calcium, right? When there is increase in ionized calcium, you know this is the form which regulates parathormone release. And we know very well whenever there is increase in ionized calcium, parathormone secretion is suppressed. And when parathormone secretion is suppressed, that decreases total calcium. And the decrease in total calcium is in such a way that in spite of there being a decrease in the bound fraction, ionized calcium is normal. Yeah, ionized calcium is finally normalized. So what do you observe in this condition? In this condition, the functional form of calcium happens to be normal at one point. Momentarily, there is an increase in ionized calcium, but because parathormone comes into action, at one point, ionized calcium has become normal. But which calcium is low? Total calcium is low. So if in your laboratory, you are estimating calcium, total calcium, it is going to be a falsely low value. So I'm going to repeat this. If a person has got hypoalbuminemia, if a person has got hypoalbuminemia, for a given total calcium, when there is hypoalbuminemia, bound fraction automatically decreases. So for a given total calcium, automatically ionized calcium increases. And this increase in ionized calcium is only a momentary change. Because as soon as there is an increase in ionized calcium, parathormone secretion is regulated in such a way that parathormone is no more released. Once parathormone secretion is decreased, what happens to total calcium? That is decreased. And the decrease in total calcium is in such a way that in spite of there being a decrease in bond fraction, ionized calcium level is normal. So final set point, the final set point is the functional form of calcium, that is ionized calcium, is normal in the person, but total calcium is reduced. So if in your laboratory you are estimating total calcium, you're going to give a false low value. To avoid giving this false low value, there is a correction. We know for every 1 gram per deciliter decrease in albumin, for every 1 gram per deciliter decrease in albumin below 4 grams per deciliter, total calcium decreases by 0.8. Total calcium decreases by 0.8. So what is the correction factor? corrected total calcium. Yeah, corrected total calcium is equal to the measured calcium plus 0.8 into 4 minus albumin concentration. Do you understand this? So corrected total calcium is equal to the measured calcium value plus 0.8 into 4 minus albumin. This will help you to overcome the limitation of estimating total calcium. So this is about hypoalbuminemia causing pseudo-hypocalcemia. So what is the correction factor for pseudo-hypocalcemia in hypoalbuminemia? Corrected total calcium is equal to measured calcium plus 0.8 into 4 minus albumin. So this is about effects of changes in albumin concentration. Now what is the effect of changes in pH? Suppose there is alkalosis. Yeah, in alkalosis, because because your plasma proteins are all buffers, they try to neutralize the alkaline pH. And to neutralize the alkaline pH, they give off their H+. When they give off their H+, all your proteins become negatively charged. So in alkalosis, your proteins, because they act as buffers, you want to repeat the formula. Formula is corrected calcium is equal to whatever value which you have measured calcium plus 0.8 into 4 minus albumin concentration. Because how much ever albumin is reduced from 4, accordingly your calcium will be reduced by 0.8. So you are going to add it. So it is measured calcium plus 0.8 into 4 minus albumin. This correction is only for total calcium measurement. So what happens in alkalosis? In alkalosis, because your proteins try to act as a buffer, they try to neutralize the alkaline pH, and to neutralize the alkaline pH, they give off their H+. Once proteins give off their H+, they all become negatively charged. Yeah, when all proteins are negatively charged, calcium goes and binds with them more avidly. When calcium goes and binds with them more avidly, ionized calcium decreases. So in alkalosis, there is a decrease in the ionized calcium concentration. And that is why in alkalosis, you find tetany. What happens in acidosis? In acidosis, to neutralize the acidic pH, all proteins get H+, all proteins become positively charged. When they become positively charged, they are not going to go and bind to calcium. So there is an increase in the ionized calcium levels. So in alkalosis, expect a decrease in ionized calcium. In acidosis, expect an increased ionized calcium. But for this, are you going to make any correction? You're not going to make any correction because it's an actual decrease and actual increase. You need to be only aware of the fact that changes in pH affect ionized calcium concentration. Okay, so these are the two facts which I wanted to tell you. Now about hypocalcemia and hypercalcemia. So what are the manifestations of hypocalcemia? As we know, calcium stabilizes resting membrane potential. Yeah, calcium stabilizes resting membrane potential. Hypocalcemia causes an increase in the neuronal excitability. So it presents as tetany, seizures, or QT shortening. Yeah, it presents as QT shortening. So in hypocalcemia, what are the features you expect? Increased neuronal excitability, which will be evident as tetany, seizures, QT shortening, hypotension. So all these are expected manifestations. Now, what are the causes of hypocalcemia? The most common cause of hypocalcemia is pseudo-hypocalcemia when total calcium is estimated. So if total calcium is estimated, if that is low, please estimate albumin. If you see albumin levels to be low, do a correction and then give the correct measured value. Okay. So that's the most common cause of hypocalcemia. And the second common cause of hypocalcemia is chronic kidney disease. As I told you, in chronic kidney disease, calcium levels are expected to be low because 1-alpha hydroxylase activity is reduced. And also there is parathormone resistance that is observed in chronic kidney disease. Yeah, what is the reason for resistance to parathormone action? As I said, in chronic kidney disease, the 7 to 24 PTH values are high. Yeah, I said right. Truncated PTH values are high, and these truncated PTH are not only inactive, they are actually antagonize PTH values. So hypocalcemia is very common in chronic kidney disease. And apart from these two common causes, the rest of the causes I would say are not that common. And what are the other causes? As you all know, it is hypoparathyroidism, which is true hypoparathyroidism. 7 to 84. You're right. 7 to 84. So hypoparathyroidism, pseudo hypoparathyroidism, vitamin D deficiency. What did I tell you about vitamin D deficiency? I said mostly calcium will be normal or at least low normal. So vitamin D deficiency. And then hungry bone disease. What is hungry bone disease? Suppose a person had been suffering from hyperparathyroidism, maybe due to parathyroid hyperplasia, and parathyroidectomy has been done. What happens so long there has been a bone resorption? Now there is no stimulus for bone resorption. So all calcium go and get deposited on the bone. That causes hypocalcemia. That's called as hungry bone disease, which happens following treatment of hyperparathyroidism. It is also a possibility in hemorrhagic pancreatitis. Hemorrhagic pancreatitis, wherein calcium goes and gets deposited. And then few burns cream. Yeah, cream used to treat burns. They have ethylene glycol. So when it is applied on a larger surface area, ethylene glycol gets metabolized to form oxalic acid. Oxalic acid forms oxalate anion, and that binds calcium, and that causes hypocalcemia. So these are the rare causes of hypocalcemia. So hypercalcemia is more common than hypocalcemia. For sodium, it is hyponatremia, which is more common. For calcium, it is hypercalcemia, which is more common. And what are the causes of hypocalcemia? It is pseudo-hypocalcemia most commonly, apart from that chronic kidney disease. Reason is 1-alpha hydroxylase activity is low and there is parathormone resistance. And then apart from this, we have hypoparathyroidism, pseudo-hypoparathyroidism, vitamin D deficiency, hungry bone disease, hemorrhagic pancreatitis. Very rarely burns cream containing ethylene glycol can cause hypocalcemia. Okay. Now about hypercalcemia. So as I said, the value for calcium, normal total calcium is 8.6 to 10.2 milligram per deciliter. And when the value is less than 12, between 10.2 and 12, we call it as mild hypercalcemia. Between 12 and 14, we call it as moderate hypercalcemia. More than 14, it is called as severe hypercalcemia. And though we grade it this way, clinical presentation would differ depending upon not only the value, but also the rate of onset of hypercalcemia. If it's a faster onset, even when the value is like 13 milligram per deciliter, you find severe manifestations. So it's not only the value which matters as far as hypercalcemia manifestations are concerned, it's also the rate of onset which matters. And that is why the most common cause of symptomatic hypercalcemia would be malignancy. Yeah, the most common cause of symptomatic hypercalcemia is malignancy. What are the symptoms of hypercalcemia? I said for hypocalcemia increases excitability. So hypercalcemia stabilizes resting membrane potential, does not allow cells to get stimulated. So initially they present with just lethargy. Yeah, they just say they are tired, they have muscle pain. So all non-specific symptoms like memory loss. So these are initially present non-specific manifestations when there is mild hypercalcemia. And then when it becomes moderate hypercalcemia, what is expected is because calcium stimulates gastrin. Yeah, calcium stimulates gastrin release from stomach antrum, and that stimulates parietal cells to secrete HCl. So they present with gastric ulcers. They often complain of nausea, vomiting, and abdominal pain. And because calcium stabilizes resting membrane potential, colonic motility is suppressed. So they present with constipation. So all these are GI symptoms: gastric ulcers, nausea, vomiting, and constipation. And apart from this, when calcium level is even more elevated, it presents as nephrogenic diabetes insipidus. Yeah, nephrogenic diabetes insipidus. There are so many theories behind, or hypotheses behind, why hypercalcemia causes nephrogenic diabetes insipidus. One is calcium is found to cause apoptosis of aquaporin 2 channels. Yeah, it causes apoptosis of aquaporin 2 channels. So it presents as nephrogenic diabetes insipidus. So they present with polyuria, polydipsia, dehydration. Most hypercalcemic patients present dehydrated. Why dehydrated? Because there is nausea, vomiting, and there is polyuria, polydipsia. So because of this, they are mostly dehydrated. And apart from this, as Nushin has typed, they present with renal stones. Calcium supersaturation in renal tubules can present as renal stones. And cardiac abnormalities. Yeah, it can present as QT abnormalities and arrhythmias. Arrhythmias are very common in hypercalcemia. So these are the manifestations of hypercalcemia. So initially they present with non-specific manifestations like lethargy, dullness, tiredness, muscle pain. And then it presents with gastric ulcer because gastrin release is stimulated. They present with constipation because GI motility is suppressed. They present with nephrogenic diabetes insipidus, polyuria, polydipsia. Totally they are dehydrated. And they can present with renal stones and arrhythmias. Okay, these are the manifestations. And then coming on to causes, as I said, the most common cause of hypercalcemia in an inpatient, in an inpatient would be malignancy, because as far as malignancy is concerned, the rate of onset of hypercalcemia is faster. And what are the causes of malignancy presenting as hypercalcemia? It can be because of tumor invasion of bones. Yeah, it can be because of tumor invasion of bones, or it can be because of humoral hypercalcemia of malignancy. It can be because of humoral hypercalcemia of malignancy. So what are the humoral causes of hypercalcemia in malignancy? It is because of parathormone related peptide release from some malignant cells. Yeah, parathormone related peptide release from some malignant cells. Example is squamous cell carcinoma. Most commonly it is from squamous cell carcinoma, or bladder cancer, breast cancer, ovarian cancers. Yeah, most of these cancers, they release parathormone related peptide, and this acts on its own receptors, causing hypercalcemia. Sometimes some malignancies release parathormone itself, not parathormone related peptide, parathormone. Example is small cell carcinomas. Vasundhara Devi has mentioned small cell carcinoma or adenocarcinoma of lung. They release parathormone. Yeah. Sometimes hematological malignancies release cytokines like tumor necrosis factor alpha, interleukin 1, and these stimulate osteoclasts, and that causes bone resorption, increasing calcium. Okay, and then lymphomas, as I told you initially, they have 1-alpha hydroxylase activity. And this 1-alpha hydroxylase increases 125 dihydroxycholecalciferol, increasing calcium. So though we say the most common cause of symptomatic hypercalcemia is malignancy, under malignancy presenting as hypercalcemia, we have many causes. One, it can be because of tumor invasion of bone, or it can be because of humoral hypercalcemia of malignancy. There are many humoral factors which can cause hypercalcemia. One is parathormone-related peptide. Most commonly, it's observed in squamous cell carcinoma, bladder cancer, breast cancer, and ovarian cancer. Sometimes it's PTH itself, which is released by small cell carcinoma of lung and adenocarcinoma. TNF-alpha interleukin-1 can be released in hematological malignancies. Lymphomas exhibit 1-alpha hydroxylase activity. This is about symptomatic hypercalcemia causes. And the most common cause of asymptomatic hypercalcemia or hypercalcemia in an outpatient is hyperparathyroidism. Primary hyperparathyroidism. And I told you about causes of primary hyperparathyroidism. Most commonly, it is hyperplasia followed by adenoma. Okay. And at this point, I want you to know how to differentiate two conditions. Yeah, how to differentiate two conditions. One is primary hyperparathyroidism. The other one is familial hypocalciuric. Yeah, it is familial hypocalciuric hypercalcemia. First, let me tell you about primary hyperparathyroidism. So, what do you expect in primary hyperparathyroidism? Here, blood calcium will be high, blood phosphate will be low, PTH levels will be high. Obviously, right? In primary hyperparathyroidism, calcium will be high, phosphate will be low, and PTH will be high. And what do you think of urinary calcium? Because parathormone increases calcium reabsorption in the distal convoluted tubule, you think urinary calcium will be less. On the contrary, even in primary hyperparathyroidism, the calcium level in urine is high, and that is why urinary calcium is high, and that is why primary hyperparathyroidism presents with renal stones. It is because the blood calcium is so high. So the filtered load of calcium is so much. So that even if there is an increase in reabsorption of calcium, even after reabsorption of calcium, the calcium that is present in urine is still high. That is why they present with renal stones. So don't expect urinary calcium to be less in primary hyperparathyroidism. Urinary calcium is high in primary hyperparathyroidism. Now, what is familial hypocalciuric hypercalcemia? So, in familial hypocalciuric hypercalcemia, it is a mutation of the calcium sensor receptor. Do you understand this? It's a mutation of calcium sensor receptor. So, what do you expect? When the calcium sensor receptor is mutated, even when there is adequate calcium, even when there is adequate calcium, this is not acting. So this does not suppress PTH release. So PTH continues to be released into the circulation. So PTH level will be high. And when PTH level is high, it is going to cause high calcium. It is going to cause low phosphate. So don't you see that it's very similar to primary hyperparathyroidism? There is high calcium, there is low phosphate, there is high PTH. Okay, but the only difference between the two conditions is in familial hypocalciuric hypercalcemia, calcium level in the urine is reduced. When I say reduced, it's not lower than the normal range. It is low for the expected serum calcium. Yeah, it is. That is why it is called as familial hypocalciuric hypercalcemia. So if you see a patient, asymptomatic hypercalcemic patient, yeah, you think primary hyperparathyroidism as a cause because you find high calcium, low phosphate, and high PTH. Do not immediately brand it as a case of primary hyperparathyroidism. Do not start looking for a parathyroid hyperplasia or parathyroid adenoma, and do not start planning for parathyroidectomy. Yeah, because it can even be a familial hypocalciuric hypercalcemia because both have similar biochemical findings. And the only way of differentiating the two conditions is you estimating calcium in urine. If calcium level in urine is less than 200 milligrams, yeah, if it's less than 200 milligrams per day, yeah, or if the calcium creatinine ratio is less than 0.01, if calcium creatinine ratio is less than 0.01, it is familial hypocalciuric hypercalcemia, in which case you don't have to ask for parathyroidectomy because familial hypocalciuric hypercalcemia is a relatively benign condition. They never present with any of the clinical manifestations of hyperparathyroidism. It is mostly asymptomatic hypercalcemia. Okay, so hypercalcemia in an asymptomatic patient, what will you ask for? Look for phosphate level PTH value. If you find hypercalcemia, hypophosphatemia, and increased PTH, before you ask for imaging studies, you ask for urinary calcium. If urinary calcium is more than 200 milligrams, calcium creatinine ratio is more than 0.01, which is most commonly going to be the case, you ask for imaging study and then plan accordingly. If it's less, it's familial hypocalciuric hypercalcemia, which is caused by a defect of calcium sensing receptor. Okay. So apart from these two causes, asymptomatic most common causes hyperparathyroidism, symptomatic most common causes malignancy. And apart from this, there are many other conditions wherein hypercalcemia can be observed. Example is drugs. Yeah, thiazide diuretics. You know, thiazide diuretics do not allow calcium to be filtered. So it causes hypercalcemia, thiazide diuretics. Lithium. Please remember, lithium is capable of stimulating parathyroid gland. I myself have seen a patient with hypercalcemia following lithium treatment for MDP. And when we observed parathyroid hyperplasia, that was removed, and then it again recurred, and that is why again it was removed, and then lithium treatment was when the psychiatrist changed lithium to something else to avoid recurrence of parathyroid hyperplasia. So thiazide diuretics and lithium can cause hypercalcemia. So these are the causes which you should have in mind as far as hypercalcemia is concerned. So summary, I was asking you a few questions. I was telling you that I get asked few questions to start with. So what is the clinical relevance of estimating total calcium versus ionized calcium? You know the answer now. What is the answer? If it's total calcium, the value can get affected whenever albumin concentration gets altered. So there should be always a correction that is done, and the corrected calcium is measured calcium plus 0.8 into 4 minus albumin. And the second question which I told you was intact and bioactive PTH. So the difference between intact PTH and bioactive PTH is intact PTH assays get interfered with N-terminal truncated PTH 7 to 84 fragments. So if it's a CKD patient, it is not the reference range that you should consider. You cannot start treating hyperparathyroidism until PTH values are 4 to 5 times higher than the upper normal reference range. And even during treatment, PTH values have to be monitored to avoid adynamic bone disease. If PTH value is less than 150 picogram per ml, we should terminate calcium mimetics because otherwise it will end up in adynamic bone disease. And then how do you differentiate hyperparathyroidism? How do you differentiate primary hyperparathyroidism from familial hypocalciuric hypercalcemia? It is just by estimating urinary calcium. If that is low, it is familial hypocalciuric hypercalcemia. If it's high, you can suspect primary hyperparathyroidism. So the summary is total calcium estimation is being done regularly. Vitamin D and PTH are the two major regulators of calcium and phosphate. Vitamin D deficiency need not always present with hypocalcemia. Many a times it's normal calcium. And we know hypoparathyroidism causes true hypoparathyroidism, pseudo and pseudo hypoparathyroidism. The difference between the two conditions is in pseudo hypoparathyroidism, you find Albright's osteodystrophy, hypocalcemia, hyperphosphatemia, and high PTH. Whereas in pseudo hypoparathyroidism, it's only Albright's osteodystrophy. A person gets pseudo hypoparathyroidism if the paternal allele is defective. A person gets pseudo hypoparathyroidism when the maternal allele is defective. And in chronic kidney disease, there can be false elevation of intact PTH. So bioactive PTH would be a better assay, but we don't have it right now in India. And then we know causes of hypocalcemia. Most common cause is hypoalbuminemia, which causes pseudo hypocalcemia. Apart from that, chronic kidney disease. Hypercalcemia, most common cause of asymptomatic hypercalcemia would be primary hyperparathyroidism. Most common cause of symptomatic hypercalcemia would be malignancy. So follow me on my YouTube channel. You can search for me as Biochemistry Dr. C. Shanmugapriya. And this is the link. And I have also released a speed learning app, Biochemistry speed learning app by name Basics to Clinics. And true to the name, I've tried to explain, no, I've not tried, I've explained all concepts related to biochemistry with clinical correlation. It's a comprehensive app covering all topics of biochemistry. Totally, you find 50 hours of my teaching videos. And it's not only a recorded video-based app. Subscription to the app will get you an access to weekly MCQ discussion sessions, which will be live session, and fortnightly Harrison's through a biochemist lens session. So for now, it's an open session, but in due course, it will be limited. It also gives you an access to crash courses before exams. We have planned for a crash course in the weekend of March, second weekend of March for NEET PG 2021. And you have an access to 1,500 MCQs. And if you want a subscription to this app, you can contact Mr. Shivakumar. This number is displayed here. Thank you. The next session will be on diabetes insipidus and SIADH. So I'll be telling you about these facts in the next session.